evening, everyone. I'm Dr. Mukul Kaushal from Chandigarh, and I'll be talking on UBE in multi-level lumbar stenosis. So whenever you think of stenosis, when it goes 2 or above, like in this MRI picture, this is a very complicated and a tough case. And probably apart from the MRI, there are other factors to consider, that this is the aging, frail population group. They have comorbidities, and we need to balance the expectations with the reality. The surgical duration is going to take time when you're addressing all these 4 levels, and probably it correlates with the experience of the surgeon and the comfort with whatever technique you are comfortable, and what would be the immediate perioperative course. So probably for such patients, the theme of this conference, that small is big and less is more, is, I think, very apt. So to take the discussion forward, this is a 65-year-old female. She's obese, hypertensive. She's a case of post-renal transplant, living with low backache since many years now, having worsening claudication, almost restricted to a homebound ambulatory state. She has intermittent perianal heaviness, and though she is continent still, she is unable to tiptoe or heel walk. The nerve root tension signs are negative. Her lower limb jerks are reduced, but the pulses are vascular. She is vascular intact. So this is her. Sorry for the poor quality X-ray images, but you can get a fair amount of idea that the disc heights have. The disc L455S1 has stabilized. She's relatively very stable. These are her MRI images. There is probably an old dorsolumbar collapse also that's not troubling her. But these are her cuts. She is stenotic at 2 levels, central and lateral recess both. So the plan was a 2-level decompression assisted by a UBE. So this is my OT setup. I usually stand on the left side. My assistant stands opposite to me. You need a C-arm in an AP and a lateral view. The patient is usually under a regional or a general anesthesia and kept prone on bolsters with neutral lordosis. So this is how you mark your markings. You take a AP C-arm, mark the midline, mark the medial pedicular line, mark your upper end of the target level disc. This is your target area, the spinolaminar junction, and you create your portal somewhat like this in line with the medial pedicular line, and for a multi-level you create it like this. So this is what the picture looks like, marking, and this is the amount of steps one has to follow to do this UV guided marking under image. So, and once you dock your scope and instrument, you start your work. But the problem is radiation. So we try to modify this triangulation to reduce this radiation exposure, and only we use our lateral view. One is we put in a spinal needle to check our levels, and once we dock our simple tube, that's it. Radiation is taken care of. So just a small tube is docked like this. I gave us another facial incision, skin facial incision. A blunt tip rod goes subfacially, hits the tube, docks over, slides over to the lamina. Over this, I introduce my scope and remove this tube and start working in a UB mode. So this is an operative video. For the want of time, I hope it plays. So this is how it goes. It was already demonstrated by Dr. Mukul Kaushal also, so I'm just
Try to speak in the mic. Try to speak in the mic. Your voice is not.
Sorry, sir. So this is a video of a UB lumbar decompression. So that's the picture which you get initially. You land on the lamina. You clear off this fibrofatty tissue over the lamina and clear the interlaminar window with the radiofrequency device. Then I try to find where is the base of my spinous process, because that's my initial working area. Then I use a simple, this is a standard arthroscopic burr, round burr. You can use it to burr away the bone. One can even use a Kerrison, whatever instrument one is comfortable with. But you have to be very careful with this burr because this can damage your scope. Once you get to the cranial limit of your flavum insertion, you will start noticing some amount of epidural bleeders also, so you have to be careful about that. Then I'm working now more towards my side. I'm undercutting the facet, and I can see the SAP medial edge, the facet joint surface of the medial SAP tip also. Now I'm going contralateral with my burr. I preserve the flavum till I do a lot of my bony work before removing the flavum. I use a simple blunt, this blunt instrument like a pen field to detach it. The epidural fat starts coming out. I take some midline bites of the flavum just to say I have the dura under my vision. And this is a very important landmark. Where is the traversing route on my side? the upper edge of the lamina and the middle border of the SAP. If I expose it here, this is where I'm going to find my traversing route. So I take some bony bites, and there's the traversing route is below there. So that is a rough guide where you will find your traversing route in the recess. So this, now I'm working on the opposite side. That is the disc on the opposite side. The route is going into the foramen at 3 o'clock. And once I've completed the decompression, usually the disc is stable, so I've not touched the disc. This is the shoulder, the axilla on my side. Midline, opposite side. Once I'm done with one level, I use my tube-guided triangulation to reduce my shoot exposure. And again, rinse and repeat the steps on the upper level. So the complications are just like any conventional surgery. You can land up with these number of complications, but what is unique to UBE is that there can be thermal injury for the radiofrequency device. If you have a lot of fluid and you're doing a paraspinal approach, you can land up with a massive abdominal fluid collection. If the inflow-outflow is not balanced, you can have high epidural pressures that can lead to visual disturbance, posterior neck pain. You have to control bleeding, and the burr has always has an inherent risk of damaging your scope. But the edge, which it scores over all other techniques, that your eye can't get any closure. It's unparalleled mobility. The over-the-top decompression, the foraminal decompression is under better visual control, and end plate preparation for a fusion surgery, it is under better endoscopic control. The flip side is that you have to additionally invest in RF bonds. You have to learn triangulation. Sometimes when you're working so close, there is loss of orientation, and even when working so close, you get a false sense that of an adequate decompression even with the less bone removal. So you have to be very careful, like Ketan sir was mentioning, the difference between a 0° and 30° scope. You can damage your scopes initially, so go with economical scopes initially. You need an assistant to hold the UV retractor and fluid related issues. So if you want to embark upon UB, this is probably a starter guide. You should join UB specific groups. So now everybody is connected online. Ask questions, visit an experienced UB center, triangulate on bone models, attend cadaver courses, initially only left-sided cases, avoid stenosis early on, use longitudinal incisions early on so that easier to convert to open or microscope if you're stuck. Take multiple checks with C-arm. If there's bleeding, always look at your anesthesia monitor, keep the abdomen free. I use tranexamic acid, radiofrequency, bone wax, neurosurgical patty, gel foam, and if nothing works, convert to a dry system or open system. And if dural tear occurs, it's better to convert to a dry or open system. So thank you very much.